Good evening, everybody. I'm Niranjana Shah. I'm a practicing internist. I have been living in Chicago for 40 years and working in the category of private internist for about 30 years. Today, we have the best host that we could find, Dr. Vivek Mohan. He is a board certified, fellowship trained orthopedic surgeon, went to uh, undergrad and the grad school in Cornell, which is very well known to everybody. And then he came to Chicago to do his residency and the fellowship training at University of Illinois. He has been practicing for about 15 years now in Chicago, and he joined IAMA, which has been our platform to do this program today. And he has been very well received, and he has been helping everybody a lot. So today he is going to enlighten us with common spinal conditions, and almost everyone has some kind of spine problems or back pain or neck pain or something. And I'm sure this program is going to be very, very helpful for us to learn a lot from Dr. Mohan. Please go ahead, Dr. Mohan.
Thank you for the introduction, and I'm glad to be part of this talk today. I have been happy to take care of patients in Chicagoland area since 2011, and been doing all types of back and neck surgeries since then. So I want to give an understanding to the people on this webinar and those who will see it later on, really just understanding how back problems are diagnosed and then subsequently treated, because I feel like it comes at all age groups, from young to old, and it still mystifies a lot of people, even a lot of doctors out there. So if you guys don't mind, please take a moment to answer the questions in the polls, because I really want to hope that you learned something out of this, because the conceptions and misconceptions out there, I want to hopefully change those and make sure you understand the facts and the realities of spine and spine surgery. So to begin with, we're going to start with the next slide here. So today we're just again talk about spinal conditions and current treatments. So back and neck pain is ubiquitous. It's the second most common cause of doctor's visits in the US, and a lot of people lose jobs and productivity due to back and neck issues. And usually everyone is at least affected once in their life. It may not be forever, but at least a few days for back or neck pain. And the most important thing we can pursue is to get the right diagnosis. And that's really the key. And to do that, usually the most valuable thing is to understand the history, the complaints of the patient, and do a thorough physical examination. And this becomes even more vital after a trauma, because subtle findings will show up that may not be apparent right away. And this is very common in spine. The true problem can often be in an area different from the complaint as well. And then the last thing is, when should patients be concerned about their problem? So common causes for neck pain and back pain. Again, these are the most common things. Trauma, repetitive injuries, and degeneration or degenerative changes are probably the bulk of it. In rare cases, people can get tumors or infections. And the final is idiopathic, meaning we just don't know what's the cause of pain. And there are patients who fit that category. A small percentage, but less than 5% likely. Again, car accidents are a bad cause of back conditions and injuries. Repetitive injuries. A lot of athletes get back conditions. Even Tiger Woods, playing golf for decades, has back issues. He recently had another back surgery. And then, degenerative conditions. This is hereditary, right? There's a lot of back conditions that are hereditary. And when you ask, if your parents or aunts or uncles had back conditions, it's often common that they did. And then this is just an image of a benign tumor. The spine is often a site of metastasis because there's very good blood flow to the spinal column. And so people who get breast cancer, colon cancer, prostate cancer, lung cancer, the spine tends to be the secondary area where it spreads too. So this is something that we treat when we need to. But if infections of the spinal column are also not uncommon in sick patients, they can get spontaneous infections as well. Okay, so let me start with describing the cervical spine. And this is the neck. You know, the cervical starts right below the skull from C1 through C7. And most common diagnoses in the neck include disc herniations, which we'll cover. They can cause nerve pain, and sometimes they can cause severe spinal cord compression, which the diagnosis is called myelopathy. That's not as clear cut as the nerve pain that we describe as sciatica type nerve pain. Cervical stenosis. This is more of like a slow process that occurs over time, usually due to age or disc compression, and it causes a slightly different set of complaints, usually pain or headaches, things like that. And then cervical spondylolisthesis. This is an instability of the spinal column that often I see in patients who either had, an injury, like a dislocation of their neck, or they've had gradual wearing and tearing of their joints in their neck, and it starts to become unstable and sometimes causes compression of the spinal cord or nerve pain. So first off, we always start, unless there's some very significant problem that causes neurologic complaints such as weakness, imbalance, bowel or bladder incontinence. If there's spinal cord damage, we have to address that urgently. But if in other cases where if it's just pain, we start with conservative treatments. And this is my emphasis in all patients. Try a good number of months of conservative treatments. So physical therapy, isometric exercises. In the neck, you can do traction. So sometimes the chiropractors will do adjustments or safe adjustments of the neck to treat these acute disc herniations. Acupuncture also sometimes helps for more nerve-related pain. Activity modification is very important. Taking rest from either work or activities and running or heavy lifting is important when you have these issues. Anti-inflammatories, that's what NSAIDs are. So non-steroidal anti-inflammatories such as Aleve, Advil, naproxen, Motrin, ibuprofen. Those are good to take for short periods of time to help you get through the pain. Oral steroids are great for nerve pain that happens suddenly, and it really does help with reducing the inflammation around the nerve. A lot of the nerve pain that does occur in these situations are due to the inflammation on the nerve from the environment that the disc is pushing on the nerve. And also my philosophy is avoid narcotics. I know we have an opioid epidemic starting to show signs of improvement in some cases, but I still limit narcotics until after surgery. So if you aren't getting surgery, I will likely not recommend taking narcotics. Cervical spine injections are the next stage. So if pain is severe or you're unable to function due to the pain, injections are a great option. And it depends on the exact problem. If there's a disc herniation with severe nerve pain, such as this picture shows, where the bones are in the middle and the discs are the blue, and the nerve is yellow, the nerve roots coming off are the yellow lines. There's one red that's inflamed. Injecting steroid around that area specifically will help reduce some of the inflammation on the nerve root. What we are hoping is that will reduce the pain while you're in physical therapy, that the movement of the disc will get out of the way with the therapy. And eventually the neck pain will resolve, the arm pain will resolve. And that's the goal. It may take a few months, it may take 6 months, and it's hard to say, everyone's different. But the nerve pain is something we follow closely. If there is mostly just neck pain or isolated, what we call axial pain, really just in the vertebral column without any nerve component, that's even less of an urgency to do any surgery. We try to recommend other options. One of those things is we call facet joint injections, where we, just like in the knee where we inject cortisone, you can do that in the spinal column, in those joints between each vertebrae. If there's arthritis in the area, or if it's inflamed, from an activity or an injury, that will help sometimes alleviate the symptoms. If those do help but do not last long enough, the next step is something called a radiofrequency ablation, which can help alleviate the pain for a longer period of time, usually 3 to 6 months. So cervical myelopathy is the next condition, and this is more serious because this is severe compression of the spinal cord in the cervical or thoracic levels typically. And the complaints are slightly different. Pain is not usually the primary complaint of pain. I'm sorry, primary complaint from the patient, but usually balance issues, loss of dexterity in the hands, numbness in the hands, difficulty playing musical instruments or typing, and headaches, oftentimes with certain positions or prolonged activity, numbness and tingling in the hands or feet. As you know, the spinal cord starts in the brain, goes all the way down to the nerves in the lower back and then into your feet. So whatever affects you up higher in the spinal cord, such as the cervical spine or the neck, will affect everything below it, which includes all the way down to the feet. So you can get tingling in the feet from a compression in your neck. Loss of dexterity is not uncommon, and that's what I just mentioned before about the changes in handwriting or musical instruments. You might have feeling like you can't properly write. So these are the cases where you got to do a thorough physical exam, which requires, either the doctor, the neurologist, or the surgeon to really check everything. These are subtle changes, and the patient may not tell you exactly what the diagnosis is. You have to discover it as a provider. So cervical myelopathy, this condition specifically shows spinal cord compression. As you can see on this MRI image of a patient, the spinal cord is getting severely compressed by both the disc herniation and ligament in the back of the spinal cord. In that area, the spinal cord becomes bright because of inflammation. So right in the middle, there's a signal change due to the compression of, like a pinching of the cord. And this decreases the blood flow. It decreases the signals going from the brain down to the leg. So again, coordination, reflexes will be abnormal, and oftentimes strength will even decrease. And oftentimes these need relatively urgent surgery to preserve spinal cord function and prevent worsening. So when do people have to get neck surgery? And this is a question I get from patients all the time. And I even saw a nurse today who needs it, and she wants to know, when is it when I have to have it? And pain is one condition. If you fail to improve with pain, especially with the arm and numbness and weakness, then after 3 months, if it's not better, it's usually recommended. Studies have shown now that if you wait past 6 months with nerve pain, that the recovery is likely not as good. So even if you get surgery after 6 months of nerve issues, the nerve recovery won't be as ideal as if you did it before 6 months. But nerve complaints and motor function, weakness, those are the reasons to get surgery sooner. Don't wait on those cases. I believe we do have a question, and one attendee asked, what is tandem gait? So tandem gait is what I call the DUI test. So the DUI test essentially is walking heel to toe, so putting one foot in front of the other, but right against your foot in front, one at a time. And if you cannot do that, as long as you're not drinking alcohol, if you cannot do that, that's a good indication of something going on in your brain or upper spinal cord. And so surgery for these conditions is required to preserve neurologic function and prevent worsening. And in some cases, if it's too severe, even if we do surgery, you won't regain anything that you've lost. So it's important to address it. It's rare that I do surgery for just neck pain. I wouldn't recommend it for just arthritis of the neck or arthritis of the discs, meaning degeneration of the discs. Without nerve pain or nerve compression, surgery is not necessary. The nerve injury or nerve compression is really the key reason to do surgery. So this is kind of the cascade of intervention that we can do as physicians, and specifically surgeons. We start with the conservative care on the left, where we just try to reduce the pain, restore alignment, and restore conditioning. And the next step is to try injections and acupuncture, maybe a little bit more invasiveness. Then the third step is non-instrumented surgery, so where we do decompressions or remove a disc herniation without putting any implants in. That's, the next step. Then after that, the next level of intervention is a disc replacement. So you're removing the problem, meaning removing the herniated disc or the nerve compression, but maintaining movement and alignment. So it allows people to go back to doing their normal activities, whether it's sports or running or heavier lifting. And that's what we are trying to do now in 2025. 15 years ago, we didn't have those options. So this particular set of surgical options were not available back then. But surgical fusion has been around for probably 50 years and still works very well in a select group of patients. I don't recommend it for everybody, but after failing everything else, and if it's well indicated, people do very well with fusions. And I think that's a misconception a lot of people have. And there was a question in the poll that what is the most common surgery? And 8 out of 14 picked lumbar fusion, which is actually incorrect. Lumbar microdiscectomy is the most common spinal surgery in the world, and including the United States. A microdiscectomy is where we just trim out the disc material and through usually a little opening in the lower back. These are all lower back conditions that I talk about in this poll here. All right, let me just go on to the cervical spine. The next slide here shows a fusion patient I took care of many, many years ago. And, he went back and was able to perform all his activities. And in this particular surgery, we don't go to the back of the neck. We actually go to the front of the neck. It's actually an easier procedure with less pain and earlier recovery. The only downside of doing a cervical fusion is that in the long run, in 15 years, you will have some adjacent level degeneration because the other levels above and below it are doing more work. And that is a known risk factor. We try to do fusions in patients who have more arthritis, such as patients over 60 or 65, because the chance of having adjacent level surgery is a little bit less in those patients if properly indicated. So the option other than that is a disc replacement, but I'll come to that in a minute. This is a case example of a 40-year-old woman was involved in a rear-end collision. She had severe neck and right arm pain, she had headaches and dizziness. She sustained a herniated disc at the C6, C7 level, which is shown here in the middle where you see the spinal cord. This was causing nerve pain down her right arm. And then subsequently, after about 6 months, she was noticing weakness. She had tried physical therapy for at least 4 months. She had done the 2 epidural injections, hoping to get rid of the pain. Relief was only short-lived for about 3 to 4 weeks. So then we recommended surgery. We did a fusion, and she underwent an outpatient cervical C6, C7 cervical fusion. We went through the front. The surgery typically is 1 to 2 hours, and in her case, she was sent home 4 hours after surgery, which is pretty typical for a 1-level surgery. Sometimes sooner now, the protocols have changed. Surgery was done about 3 years ago. Depending on your health, you may need to stay overnight in the hospital. And she was able to stop her pain pills within 6 days, which is what I typically see. Most people don't take their pain pills after a week if the surgery was done for the right reason. And I did not address any of the other levels, even though you see some bone spurs at the other levels, because we don't need to. This was the affected level. And she was able to travel even to Alaska 2 months later for a trip with her family. Mm-hmm. I see we have another question. Let me just look at that. Can a surgery be done before getting epidurals? As I understand, epidurals weaken muscles. Does the insurance allow this? So yes, surgery can be done before epidurals. And, there's no evidence specifically that epidurals weaken muscles. If you have diabetes and it's not well controlled, epidural injections will increase your sugar levels and potentially make your diabetes worse. Insurance will allow you to avoid getting epidurals, but they still require a certain amount of conservative treatment, meaning physical therapy, at least for 6 to 8 weeks. On the other hand, if you have severe neurologic issues such as weakness, abnormal gait, imbalance, significant findings, they will approve surgery even without physical therapy or injections, because those are severe findings that need to be addressed urgently. Waiting with physical therapy is shown to be detrimental to the overall return to function. So going back to the slide, so a cervical artificial disc replacement has been available for about, I believe, 12 to 13 years now in the US. And for the last 10 years, roughly, it's been approved for 2 levels. And this is also excellent surgical option for patients with 1 to 2 level herniated discs that cause compression of the nerves, because it does maintain the range of motion of the patient. They can return back to work quicker, roughly 3 to 4 weeks. You can pretty much go back to playing sports, traveling. I just don't recommend contact sports after the procedure because it will, risk, shifting. But again, in older patients with a lot of degeneration, it may not be the ideal surgery. And so this is something that it's, something to discuss with the surgeon. This is the best surgery for you. And you have to really do a good understanding of your MRI. A total disc replacement does, again, like I said, restore the height, stabilize and allow motion, and it decompresses the nerves. So you have removal of the nerves. So it allows the disc to move without pinching the nerves. So this is another patient of mine several years ago. He was a 35-year-old male with long history of neck and arm pain with numbness into the hands. Right was worse than the left. Failed to have consistent pain relief with physical therapy, and he had multiple epidural injections over the years because he traveled a lot for work. And in his case, this is a little bit of a harder MRI to understand, but I take 2 slices. The top slices for the C5, C6 level on the left, and the lower level C6, C7 is on the right. And the view on the right side of each picture is the slice across it. So the side view shows the disc that's protruding out in the spinal cord going in the spinal canal. And then the other view, you can see where the red arrows are showing the nerves getting pinched by the disc protrusions at that level. And the spinal cord is also moderately compressed at those levels. So in his case, because he was young and quite active without a significant amount of arthritis, the disc was the issue. We were able to do a disc replacement, and he did very well. So these are the images. He was able to return to work and travel within about 6 weeks. So now going on to the lower back, we want to talk about, there's similar conditions, but slightly different anatomy and anatomical considerations. In the lower back, we basically have 2 types of pain. There's acute and chronic pain, but then we also break that down. Is it neuropathic or nerve-related pain like sciatica? Or is it nociceptive pain? Is it related to a joint or a disc or a ligament in the lower back? And this is where, many providers hate, low back pain because they really don't know where it's coming from. You ask independent internists and general orthopedic surgeons, this is like a area they're not a big fan of because they don't know what's the cause of low back pain. And sometimes it's a very, very tricky area. But this is where you need to have a good examination. The doctor should take a good history from you to really understand what the pain source is. And I'll get back to why it's important to understand everything. So again, like in the neck, the lower back can have disc herniations. It can have arthritis and disc degeneration. You can get fractures, of course, and you can get spinal stenosis, which is the narrowing of the spinal canal. And there's usually typically 2 types. One without instability, where everything's stable, but the spinal canal is very narrow. And there's width instability where there's a shift in the lower back, in the vertebrae, that's causing instability. Scoliosis, which is the curvature of the spine, is also a form of instability, and I'll show you some images of that. Sacroiliitis is actually quite a common condition, but I don't want to go into it too deeply here, only because it's a long understanding, but it's basically the pain between the tailbone and the pelvic bone. Very common in women after pregnancy. They have low back pain because their pelvis is opening and closing during pregnancies, and women who've had multiple kids, it tends to flare up quite a bit over the years. So the most common condition in the lower back is typically a herniated disc, where, like in this person's image here, you see where the blue arrow is, the side view on the left shows the herniated disc coming out. And then on the front picture in the middle, the blue arrow points to where it's coming out, and it's actually pinching the nerve on the right side. The right half of that image is the left side, and the left half of the image is the right side. So MRIs are flipped upside down. But anyway, it's pinching the nerve, and the opposite side, the nerve is wide open. You can see those little dots, and those represent the nerves in the spinal canal in the lower back. So unlike the spinal cord in the neck, the nerves in the lower back are actually fibers. They float around in there and have more space. But the pain is much more intense because the nerves, unlike the spinal cord, have pain receptors on them and can sense it very significantly. So the symptoms typically numbness, tingling, pain with bending or in certain positions, sometimes even sitting for a prolonged period of time can cause the nerve pain, like sitting in a car. And when severe cases, you can get foot drop, which means that you can't pick up the foot or you can't push off with the foot. And in those cases, you typically need to see a surgeon urgently, because if you do have weakness, again, I want to remind everyone, weakness is a finding that's severe. If you don't get it treated soon, the chance of it recovering is poor. So spinal stenosis. So in this case, in this image here, spinal stenosis is present with instability. So if you look at the image, you look at the vertebrae on the side, they're all nicely lined up except for between the third and the fourth lumbar vertebrae. The fifth one and the tailbone at the bottom are fine, but the third and fourth, you can see a shift. It's like a trapezoid as opposed to a rectangle. And that disc is shifting because it's unstable. And the instability is leading to compression of the nerves at the level where you can see it's darker and hazy because there's not much space. The spinal fluid, which is white, is limited in its flow at that area. So in a normal slice, you'll see the spinal canal behind the disc. You see the dots here in the middle picture. Those represent the nerves, and then the sac around it is full of fluid, a lot of space, no problem. Then when you see a picture with a lot of spinal stenosis, you can see there's barely any space for the nerves. It's very clumped together. And in these cases, people can get a lot of pain, but because this may take time to occur, the pain may not be severe initially. What usually occurs is they have difficulty with prolonged walking. They have to stand and sit every so often, maybe 1 or 2 blocks, maybe after 10 minutes. And then as time goes on, that time frame becomes less and less and less. You might know a parent or an uncle or an aunt or a sister or a brother that may have this issue that they've noticed over the years progress, where they can't walk or stand for more than a few minutes. And it can sometimes present to us in the clinic with nerve pain, numbness, or weakness. And in severe cases, if this is ignored, it can develop bowel and bladder incontinence. And at that point, you have 8 hours to address it. Otherwise, the patient will not recover their bowel or bladder control. So this is a very important fact to tell all your family members. But in general, treatment for lumbar conditions, if they're started in the early phase, we try medications, and there's injections similar to like the neck, where we do epidurals or facet joint injections. We avoid any narcotics preoperatively. We can do ablations for for joint pain. We can do ablations in the neck and in the lower back. Physical therapy is a core component of this. Unfortunately, a lot of people these days, around the world, sit at a desk for 8 to 10 hours a day, if not longer. And that creates a weak core and a weak back. So to compensate, you need to spend 30 to 45 minutes a day doing some type of exercise or activity, Walking is a good exercise for people who are older, but in young people, they need to do some kind of core workout like yoga, Pilates. And then I see that many older people do those strenuous exercises and they're doing okay. But just make sure your doctor or orthopedist says you're healthy enough to do those things without damaging yourself. Seeing a physical therapist was the first way to really get to those levels without hurting yourself. I know we have a couple of questions coming up here, and one of them asked, is a bulging disc same as a herniated disc? And this is a question I get asked a lot because it's almost an interpretation. It's like art. So in this case, so like in this MRI here, the two bottom discs you see here are actually essentially, in my mind, normal. They're very minimally degenerated. There's no compression of the nerves. The disc above the stenosis area, which we call L23, is slightly bulging, very minimally, very, very minimally. And even the one above that is very minimally bulging. So these are what we call minimally bulging discs. The slide before that, this is a true herniation because you can see there's material coming from inside the disc, outside the disc, and pinching the nerve. This is considered a herniated disc. But the spectrum is a very subtle one, and it transitions. There's no really hard transitions. We all know what a herniated disc looks like. We all know what the disc bulge or protrusion looks like, but the differentiation and where we draw those categories are kind of blurred. So what a radiologist calls a herniation or a disc bulge, I may call a herniation and not a disc bulge. So it varies depending on the provider. But more importantly, that really the important part is what are your symptoms and how do they correlate to your MRI? That's really what you want to get out of your visit with your physician. And they should show your images, and you should really get an understanding of what your images look like. And if you don't bring your CD, sometimes your doctors may not have it. So make sure wherever you leave your facility for your MRI, get that CD and bring it to your doctor. So going back here, there was one more question about PRP and gel injections. Are they upcoming options? So right now, in the spinal column, gel injections are not an option. They're still in study phase. There are a bunch of studies around the world. They're testing different types of cells and cellular injections, stem cells and other things. There's no gels right now that are working. There are a couple of Medicare approved injections. I don't know how well they work. There's still some studies trying to show if they provide any benefit. In some patients, especially young patients in their teen, I recently operated on a teenager with a herniated disc. In those patients, I do recommend getting a PRP injection if it's cost effective, because unfortunately they're not covered by insurance still. But PRP is basically your own blood, where it's spun in a centrifuge, and then we take the platelets and inject it into the disc. It's shown some promise. The data is still being teased out across the world, so I can't say it's definitive yet, but it's getting there. It's an important fact to know that there are new modalities, but I don't recommend injections into the disc for just for nerve pain. I recommend it for back pain if you just have a disc pain, and you can try it out. I think it's a great option, especially if you're not really healthy enough or not interested in surgery. It's a good option. If your pain is severe and you want to be more active, then it may not be the best solution. But PRP is something that I do offer to some patients, depending on their situation. And I will say this, older patients with degenerative disc disease, I don't know I don't foresee that to be the biggest issue in that population, especially over 65, because at that age, their discs are usually calcified and stiff as it is. I think more of their pains are coming from nerve compression, instability, bone density issues. So there's a lot. Age really makes a determination of what the condition and the treatment you need to provide. It's part of the whole puzzle we utilize. So one of the things I often emphasize to patients is aerobic exercise, and it's important because you need blood flow. Aerobic exercise also allows improved nutrition to your discs. because when you're a child, your discs get blood flow directly. As you become an adult, around early 20s, your discs are not getting any blood flow directly. It's having to get nutrients through osmosis from the bone. However, unfortunately, if you have a poor diet or if you smoke, those discs will deteriorate faster. So it's important to have a healthy, balanced diet, a lot of vitamins, nutrients. Vegetables are important, and iron, calcium, vitamin D. If you're not lactose intolerant as an adult, dairy is a great option. Obviously, avoid the overlying fat and cheese, but it's important to balance it all out. But I want to impart some knowledge here. So this is a patient I saw several years ago, and you can see he has two lower discs that are kind of degenerated. He didn't have any nerve pain, just back pain. And he had tried some physical therapy, but in reality, I think there's an overlying issue here. And if you look at the MRI shows a significant layer of fat behind the spinal column. And the reason this is significant is because obesity doesn't mean that you're unhealthy. I've seen some very healthy people but are obese, but it indicates inactivity. And that is sometimes a cause of low back pain. And so I think it's important to work on weight loss and health to improve your condition, especially if you have a lower back condition. And if somebody does have a surgical issue like a fracture or an instability, it's ideal to be healthy because obesity only makes the recovery harder. So it's imperative to be healthy as you get older because you might get an injury that you weren't expecting, and then now you need surgery urgently, and your health issues are going to lead to a harder recovery or a higher risk. And this is a big consideration as a surgeon that we have to take into when you see us either in the hospital or in the office. And vitamin levels, like I mentioned before, is a very important factor here. Many people are vitamin D deficient, vitamin B or B complex deficient, and these are important things to address with your primary care doctor on a regular basis. Dr. Shah and other internists like her will do this in their office. Again, going back to the cascade, starting where the conservative care on the left side, all the way to the fusion on the right side, being the most invasive and restrictive in the long run. So there's an increasing degree of surgical invasiveness here. So microdiscectomy, as I talked earlier briefly, where we just trim out the herniated disc, that's the least invasive, and that's the most common surgery that we do in spine surgeons. The next one is a laminectomy. Very similar to microdiscectomy, but it's typically utilized in older patients where they have more arthritis buildup and they're having a lot of pressure on the nerves in spinal stenosis. Without instability, we can just do a laminectomy, and that relieves the nerve pressure. And that usually works in the majority of patients. But when you have instability with it, then you need a fusion. But going back to the disc replacement, that is something that's been around now for the last 7 years, and I've been utilizing it in younger patients who just have bad discs, low back pain that have been failed to improve with at least 1 to 2 years of treatment. They have severe back pain with a little bit of leg pain, or they've had herniated discs over the years. It's getting recurrent. I recently did a disc replacement on a gentleman in his early 40s, but he had his first surgery in his 20s and the second one about 5 years ago. And then at this point, we got to do another surgery. Instead of doing a fusion, you can do a disc replacement in those categories. And again, the disc replacement, you can return to function faster and sooner, and also return to pretty much all activities, including sports, pretty quickly. Again, a lumbar fusion is reserved for certain cases. I don't recommend it for everyone. I think it's really important to understand why you're getting the fusion. I think that's a misconception that people have. Fusion is not the reason people should get surgery. Surgery should address the problem, and the nerve compression is the problem. So this is an image I would usually take in surgery. It's an X-ray, and this is the tube I place. Typically, it's about an 18 millimeter tube, or a little bit over 1.5 centimeters wide. And I use tools to go down there to trim out that herniated disc. And this is the most common spinal operation that we do. It's 90% are done as an outpatient. In older patients or sick patients, it may need to be done in the hospital. And nerve pain should resolve very soon or very quickly after. And usually we can recommend patients return back to full activities within 6 to 8 weeks. But I tell patients to really be careful because there's a hole in that disc. And if they overdo it, more disc material will come out. So you got to imagine that the disc is like a jelly donut with a hole in it. You keep putting pressure on it, like by running or bending or lifting, more of that gel is going to come out and pinch the nerve again. So you got to be careful in the first 6 to 8 weeks. So like in this particular case, severe spinal stenosis, this patient did not have any instability. So a laminectomy would suffice. And that's a good particular case. So laminectomy is a procedure where we open up the space, the spinal column, and it can be done open with a small incision in the middle, or minimally invasive, which is like the tube, like earlier I explained. And this can also be outpatient if it's 1 or 2 levels. Usually in older patients or large or more levels, it probably needs to be done in the hospital for an overnight stay at least. So this is an example of an X-ray of spinal fusion I did many years ago. And these are done minimally invasively now. I make 2 little incisions. And it's not for everyone. I think you have to put the surgery for the right patient for the right time and the right anatomy. And that's the key. So the goal is everyone gets to customize, should get a customized treatment to what their goals are. And if a fusion is necessary, we try to be as least invasive as possible when we do the fusion. When I talk about invasiveness, you're still going to get, if you're going to get a fusion, you're going to get screws and some implants. So the question is, how do we get it in there? And what are we doing? And the purpose of the fusion is, 1, to stabilize if there's an instability. 2, if there's a disc herniation that keeps coming out, you don't want to, you want to get rid of it permanently, take it all out, and we put a cage in there to restore the alignment and also eventually fuse across it. Or 3, to correct a deformity like a curvature or an abnormal fracture. And that's when you need screws and rods. And we can do it minimally invasively without taking out muscle and causing a lot of damage to the other adjacent structures. That's what we call minimally invasive surgery. It's not like in the belly where we use cameras, though that is coming up in spine now too. But still, you got to put these screws in, and the only way to do that is through small incisions at least, without disrupting the muscle. So this, if you got to take anything away with this presentation is this. And what are the common reasons for a spinal fusion? The most common reasons are spinal instability. So abnormal curvature of the spine, which is called scoliosis. It's actually very common in children and adults as well. Not everyone needs scoliosis, but if your curve is over 45 degrees or 50 degrees, it's typically necessary at that point. Spondylolisthesis, which is the instability that I showed before. Spondylolysis is actually a common problem that arises, and it can be either be formed at birth or it can form through certain activities like football linemen, repetitive hyperextension, or gymnasts even. And that can create an instability as well. And severe spinal stenosis. So there is some rare cases that anatomically patients have severe compression of the nerves, and to be able to open it up, you cannot only do a laminectomy, but you have to literally remove all the structures in the back of the spine. But when you do that, you're creating an instability, and to avoid making their symptoms worse or pain worse, we have to fuse it to stabilize it because there's nothing, no structures left to stabilize their spine. So those are rare cases, but that's something that's seen. Again, unstable fractures. If you fall down off a wall 6, 8 feet and you get a fracture, there's a small possibility you need a spinal fusion. However, compression fractures in old patients where they just fall down to the floor don't necessarily need surgery unless there's spinal cord compression or nerve compression. So check with the doctor regarding that. And one of the common things I see in patients in their 40s and 50s, if they've already had herniations in 20s and 30s, They now have another herniation again at that same level. Fusion is still a good reason to do the surgery because it will alleviate their issue and get rid of that pain source permanently. But a disc replacement is an option for some of those patients now. So this is again a fusion for this individual that had the instability and the stenosis at the L3-4 level. We put screws and cages at that level. This is a spinal fracture. This is a lady that was climbing a wall at a gym, and she didn't use a harness. She fell about 12 feet. And this is an unstable fracture because it involves the back half of the spinal column. And we call it a flexion distraction injury. As you can see, there's a gap where these arrows are. And that's a severely unstable fracture. Oddly enough, she was walking in severe pain at a restaurant with her parents before she came into the ER. But she ended up getting surgery and did very well in recovery. A lumbar disc replacement, again, is a good option in patients who fail to improve for at least 9 months with conservative care. So if you've had treatment like chiropractic care, physical therapy, injections, medications, for at least a year or at least 9 months, this is a good option. Disc replacement is a good option where you have normal joints and otherwise a normal spine, with the exception of 1 or 2 bad discs. You can have a replacement where you can go back to functioning very quickly and being able to be active, doing sports and moving and traveling without significant restrictions. But this is, again, very selective. You have to find the right patient for this. Again, so these are the indications. We can do a disc replacement if the joints in the back of the spine are in good shape. Again, I don't recommend a lumbar fusion for disc degeneration. That's not the reason to do it. So every surgery we do, either a decompression or a fusion or a disc replacement, we have to find the reason why are we doing it. And that's the reason. Not everyone with a bad MRI needs surgery. And not everyone with pain needs surgery. You really have to find the right patient with the right problem. And then if they fail to improve, then they get surgery. So this is a patient that I took care of many years ago. He's a 36-year-old. I'd done his first discectomies a year prior, did well. He was actually on narcotics for many years from another doctor, but he re-herniated after falling down. And he was struggling because he was having a lot of nerve pain, leg pain, and he ended up having re-herniations. And if you can see here, he's got 2 very bad discs, but other ones are all really good shape without any degeneration or herniations. And prior to 2018, essentially, I would have had to do a 2-level fusion. There were many patients in the past I had to say, listen, the only option we have for you is a 2-level fusion, even young patients. But in his case, we were able to do a disc replacement at both levels. He was actually the first one in Illinois to get a 2-level disc replacement. And he was able to return back to work full duty at 4 weeks. Again, I only restrict patients from diving or contact sports after this, but they can walk, they can bike, they can swim, they can play tennis, golf. So we encourage movement after surgery for this particular procedure. Again, important points. Not all spine cases are alike. You might have the same MRIs, but different symptoms. So we treat the symptoms. They have to correlate properly. Spine deformities are more common as we age and may require surgical intervention. So that when I say deformities, I mean instability, fracture, not fractures necessarily, but scoliosis. You might get fractures that eventually cause a deformity we call kyphosis. One of the important points that we've seen as surgeons is we avoid surgery in older patients now because we've noticed that the recovery is harder, you have poorer outcomes. So if you're older but very healthy and you want to get back to being active, I think it's a good option for having surgery. The oldest patient I've done the spinal fusion on is 86, and she was very active, independently living, very healthy, no heart issues, nothing. And she did phenomenal. So you have to pick your patients. I've seen 40-year-olds that are not very healthy. So really, it's important to understand why we're doing what we're doing. And then nerve compression is the best reason to have a surgical intervention for your spine. And these have the best outcomes from surgery. I'm going to go back to answering some questions we have here, two more. Sometimes I get lower back pain and hip pain on one side when I walk slowly, but quickening the pace helps when I walk away from my friends. So I can't exactly say why that's the case. Maybe you don't like your friends, I'm not sure. But I think that the problem is maybe that when you walk faster, your muscles are activating your back and it prevents you using your joints and the muscles are working, and that might help with the pain. Sometimes just the movement helps. Somebody has a question about coxa of the hip, causing internal rotation limitations and malalignment. Coxa of the hip, unfortunately, not a spinal condition. I can't give you a good answer with that. Depending on your age, a hip replacement might be the best option. But again, unfortunately, this is, beyond the scope of this topic. But please definitely see your hip specialist and see what options they'll recommend. And the last question posed right now, 60-year-old with osteoporosis and bisphosphonates, would a surgery cause concerns? So actually, we put people on bisphosphonates for osteoporosis, and we usually don't have any issues with surgery. But I will say that you do need like a holiday. We call it a bisphosphonate holiday or Fosamax holiday. So after a couple of years of being on bisphosphonates like Fosamax or alendronate or whatever one you're on, we take a break from it, because what happens is your bones may be brittle, like a hollow when they're osteoporotic, but then as you get older, it might cause your bones to become like chalk. They'll be harder but brittle, and sometimes you can actually get fractures from it. It's called stress fractures essentially, and that might be fixed. So that's why we've learned over the last 2 decades to take breaks from Fosamax. Reclassed is the one they've stated that they take once a year. So the biggest issue with the once a year medications that we have is in some rare patients, rare cases, it can actually cause destruction of your bone. And we usually see it in the jaw. So dentists actually hate these medications because in some rare cases, they'll see a patient come in and the jaw is just like disappeared because it's caused bone destruction from the medication. But we call it an idiosyncratic reaction because we can't predict which patient it's going to happen to. So that's something that you got to discuss with your doctor. I'm a little bit more on the side of caution where I prefer taking the once a month or once a week pill, because at least then you can control it if you need to stop it. If you do the reclass once a year, it's hard to go back from it because you've already taken it. So, but again, that's a discussion you have to have with your either endocrinologist or primary care doctor and see what's best for you. But osteoporosis is a big problem, and more spine surgeons are having to address it. So what I'd recommend as patients get older, especially postmenopausal women, is to make sure you check your vitamin D levels and calcium levels. You can even lift weights. They've shown improvement in 90-year-old women lifting even 5 to 10 pounds, showing improvement in bone density. So as you get older, don't just sit on the couch and watch TV. You need to move, lift, bend, walk up hills if you can. All those things will pose better benefits for you as you get older. I know, especially when I was a child, we always told the older generations to relax and rest and don't do too much. But that thought process has changed. And now we tell people as they get older to walk and to exercise. It's important to do all that. I know I'm running a little bit over. Is there any other questions? I can actually go back and answer the polls. I want to do the answers for number 2 and 3. What is the risk of paralysis in low back surgery? It's actually less than 1%. Paralysis is very rare in low back surgery because the spinal cord is in the neck and upper back. And the chance of paralysis from addressing the nerves in the lower back is less than 1%. It probably happens 1 in thousands of cases. I haven't seen it in my practice, but I've heard of it, read about it in the literature, but it's again very, very rare. So there's about 100,000 to several 100,000 microdiscectomies a year performed in this country alone. And risk of paralysis is very low. Spine surgeries can be done as an outpatient basis, discharged the same day. And the answer to that is actually all. I've done all those procedures outpatient, more often now than I had done in the past. And again, it depends on your health, your age, and the pathology, meaning what are we addressing? Is it something that's really straightforward, or does it require many levels to address? If it's going to be more than a 4-hour surgery, I wouldn't do it outpatient. I'd do it in the hospital. But all those that have been done outpatient. So I think the perception of surgery for the back or neck means you're going to be in bed for the next month is wrong. I actually tell patients to go back to work as soon as they can feel comfortable, which is usually a couple of days to a week or two for the cervical spine. It's a desk job. And then for the lower back, as long as they're not doing any heavy lifting, they can go back to a desk job, again, also within a couple of weeks. So this is a very different perception than what patients have. So there's a lot of misconceptions out there, unfortunately. Are there any other questions? And Dr. Shah, do you have any questions or comments? I'm more than happy to answer anybody's questions now.
I don't have any questions, but I do appreciate your presentation, the explanation, answering all the questions that the audience has. And I also want to thank audience for being very attentive and listening to Dr. Mohan's presentation. As we can all see that 1 hour presentation is not going to be enough to learn everything about the spine problems and spine surgeries and what to do when, but obviously going to your own primary care doctors and trying to get the proper referrals or proper imaging studies or whatever needs to be done, that should be the first step. And then depending on what's going on. So, but I do appreciate everything. And if anybody has any question, there are some emails that should be in the database where the emails can be sent to the.
I have my last slide here. If they have any questions, they can call or email us. Yeah.
So I think we'll just conclude here because our time is also up, and I think it was very well received program. And thank you, everybody. Good night.
Thank you.